Hello everyone, welcome to Talking Health with Dr. Laz, your favorite health program on television. Reaching you from your channel of choice AIT from Nigeria's capital city, Abuja. My name is Dr. Laz Eze. Yes, we're still talking about the state of the health sector, and in this year, there is still a lot of conversation going on the state of primary healthcare in Nigeria. We'll never stop talking about it until our primary healthcare system is strong enough, to provide the quality of healthcare services that the citizens of Nigeria deserve. Recently, I led a group or a team of persons, highly brilliant and dedicated health professionals that carried out a study within the FCT across the 62 wards to determine how functional or generally the state of the primary healthcare. Of course, that project was supported by a development partner. Civil society organizations and the media were also involved, and the findings are kind of interesting. Today, we are going to be highlighting those findings, and I'll be speaking to the acting executive secretary of the Federal Capital Territory Primary Health Care Board, Dr. Iwot Ndaeyo. And he's going to be talking about how the Federal Capital Territory had progressed from when the policy, the Primary Health Care Board Establishment Act was signed till date. How far have we gone? Of course, I'll be speaking to a civil society person who was one of those that went through Gwagwalada Area Council, to check through the 10 focal primary health care facilities across the 10 wards in the area council. So how can we move the needle, or how can we make things work much better? So that's the focus for the program today. So we're going to be taking a break, and when we return, we'll do this conversation more. But remember that going forward, we are going to be paying a little more attention to primary health care and how we can make it work. So we could have a segment dedicated on make our hospital work on this program. So look forward to it. I'll see you after the break. Welcome back to Talking Health with Dr. Laz, your favorite health program on television. Yes, the FCT, or Federal Capital Territory Accountability Mechanism. So carried out with the Association for Reproductive and Family Health with support from development partners. Some key assessment of primary care in the FCT, and I'm going to be showing you on the screen some of the key findings. It's not quite encouraging at all, given the resources that have been put in. For instance, looking at availability of regular water supply in primary health care, it's showing that in Abuja, out of 10 health facilities that were assessed, only 3 said they have access to regular water supply, as important as it is. AMAC, out of the 12, at least 10 said they had access, which is good. The public water supply is very, is available in AMAC, which has most of the city center. In Buhari, Kubwa, and all the other axes, 8 out of 10 said they had access to regular water supply. But in Kwali, it's just 4 that has, so 6 out of 10. And these are like the 10 model primary healthcare facilities. We did not even go to the ones that are not considered as the models. In Kuje, 6 out of 10 said they had access, so which means 4 does not have access. Gwagwalada is 50-50. So it's a major issue, and it's an area that individuals, private organizations would consider supporting these health facilities. And when it comes to regular power supply, note that primary healthcare facilities are supposed to run 24 hours. At night, you usually have, labor and delivery happening a lot at night, and as well as some health emergencies. So it's really important for there to be power supply. We have Abuja, none out of the 10 primary health centers said that they had access to power supply. So lack of power supply is a major issue in Abuja, and Kwali as well. none of the health facilities has regular access to electricity. And in Buhari is 50-50. In Gwagwalada, 9 out of 10 do not have access to electricity, regular electricity supply. In Kuje, 6 out of 10 do not have access. And in Amak, wow, even in Amak, it's just like 4 out of 11 that said they have access to regular electricity. And what is regular electricity supply? You're looking at facility that has at least 6 hours of power supply in a day, so, and every day of the week. So many of these ones could not boast of that. And these are just some of the findings, not all of them, but we feel it's important to highlight this. So looking at this now, human resource for health is also an area that we are performing very poorly. So a lot of them don't have significant number of healthcare workers. In fact, many of the people working there are volunteers, and sometimes they leave when they get a job. So there's human resource crisis in the primary health care in Nigeria's capital city, and this calls for great action. But good enough, election held last weekend in the area councils, and of course, new chairman has been elected. It is believed, and I do hope that this chairman, when sworn in, will be working with the Federal Capital Territory Primary Healthcare Board, to ensure that they fill many of these gaps. So I had conversation with Dr. Iwot Ndaeyo, who is the acting executive secretary, and this is what he had to say about the state or how his board had progressed since President Muhammadu Buhari assented to the bill establishing it a few years ago. Let's watch and hear from him.
Everybody knows what legislation means, and coming to organizational establishment and having legal backing where you can sue and be sued, it goes a long way to strengthen governance. And it's not only quality, we are also talking about access and utilization. So these 3 pillars of the healthcare services landscape cannot be overemphasized if they are to benefit from legislation. Yes, it's true that we have the FCT Primary Health Board Act 2019. That is almost over 20 years from the operationalization of primary health care in FCT. And am I calculating well? Because primary health care came into FCT in 1988, and I think that is quite some time. That we are talking about 30, for about 21 years, yes. So having that law after operating for over 30 years, and you're having establishment law for the first time, you know that in spite of the fact that the production of that law was a very robust process, National Assembly had to make laws for FCT constitutionally. And we had to pass through all the processes, particularly the public hearing, where all the stakeholders, including the traditional institutions and religious leaders, were all brought in to the public hearing. Papers were presented. It was so robust. So this is a very popular law, very, very popular. And I'm happy to say that the Minister of State, the overseeing authority for FCT Primary Health Care, did not hesitate to assent or to give approval that the assented act that has also been published in the official Gazette of the Federal Republic of Nigeria should be implemented in the FCT. And following that, in terms of leadership and governance, we are looking at the structures and systems that should drive primary health care, particularly the community managerial structures that should drive primary health care, because without the community coming in from the tripod of community participation, equity, and intersectoral collaboration, that if you remove any of these 3, there's no primary health care. So coming in with the legal framework and the provisions for the managerial structure for primary health care implementation in place, I mean, FCT was already repositioned to move forward. And remember that this is also in line with the National Health Act 2014 as amended, a part of the national health system the community managerial structure. So every state, including FCT, must deliberately facilitate the formation or the establishment of this structure to enable primary health care to flow and reach the people in need. Remember that it is about a health system that is about democratic. That is health care for the people, by the people, and of the people. So the people have to be part of it. Their resources have to be mobilized into the primary health care. They should be actively involved, and it should be at a cost that both the community and government can sustain at every stage of their development. So this is the challenge that we are having. Now everybody is looking at government as the sole driver of primary health care, which is wrong. So to that extent, we are beginning to engage the communities to have that structure, to organize community into committees as recommended by the Act and then the National Health Act too. And we have done 55 village health committees, and we have also stepped up our area councils, health authorities, because that is the beginning of interaction with the integrated approach, where the traditional institution, the elected executive chairman of the area councils, the departments of the area councils authority, they are all part of this advisory committee. And we have established that in FCT. But when you come to the FCT Primary Health Care Board, the 7 departments have been provided for. And the nomenclature of the departments have also been aligned with the national guideline. And that is to say you don't see something like Department of Primary Health Care in the board. It's Department of Community Health Services, Department of Disease Control and Immunization. So we have applied for all those ones so that we are awaiting approval. Then there should be one authority, primary health care under one roof. Primary health care under one roof is a policy that is derived from the Act. So when you have this Act, you must enforce the policy. To that extent, all agencies providing, particularly public agencies providing primary health care in FCT, are expected to come under the authority of the Primary Health Care Board, and all the personnel should be absorbed. The Minister of State has given approval to that. So we are in the process of realizing that approval so that we can absorb the 6 area councils personnel, and primary health care should come to the board. Then there's a primary health care department in the area council civil secretariat, like Ministry of Local Government. That one too has got to be absorbed. So that there will be one coordination, and we have one plan, and we roll it out there. And so when you see this fragmentation still in place, it negates the spirit of that law. And coordination is difficult. Health outcomes cannot be guaranteed. So the people suffer for that. So the earlier we push for realization of particularly the leadership and governance structures and systems in FCT, the better. Not for us, but for the expected beneficiaries.
Okay, yes, you've heard from Dr. Iwot, and I'll be speaking to a civil society person, one of those who helped to carry out this survey. He works in Gwagwalada Area Council, but that is going to be after this break. Do stay with us.
2 or 3 major things came out clearly. One is on the issue of human resource, a shortage of human resource across our primary health care centers. 2 is the issue of sustainable electricity. And 3rd one is the issue around water. And you will agree with me that all these 3 components, they are key to functional primary health care center in FCT, as well as in Nigeria generally. And after the scorecard, we also further engaged with relevant stakeholders from the World Development Center, the officer in charge of primary health care center, as well as political leaders in the Gwagwalada Area Council, to share with them the report from the field so that we can both agree on strategies to close those identified gaps, which that gave us opportunity to convene 3 accountability forum with relevant stakeholders in Gwagwalada Area Council, and those key issues were distilled and strategies were agreed on how to do it. As for example, when we discussed the issue of scorecard, the area council agreed with the report from the scorecard, meaning they are willing to close the gaps identified from that scorecard, the first thing they did was to constitute an assessment committee from the works department to visit all the identified or mapped primary healthcare centers to have the situation report on the dilapidated facilities across the area council, and also develop a strategy on how to go about it, which we suggested to them that 2022 budget is in the process. Those identified primary healthcare centers should be prioritized in 2022 budget for renovation. On issue of human resource, which is key to the area council, because they have been working with ad hoc staff. There was a recruitment after our intervention with them, and the director of primary healthcare center worked closely with head of admin, where part of the 250 employee recruited were also posted to some of the primary healthcare centers to close the gap identified around the issue of primary healthcare centers. And our interaction with WDC, that is what the community centers, shows that there is need to work closely with private sectors in the area of health financing. But the feedback we got during our interaction was that they faced bureaucracy in getting approval from the leadership of the area council to get such opportunity to support the funding in the primary healthcare center.
Okay, so you got it there from a civil society person. Talking about the solutions now, there's been a lot of conversation. Talk is cheap, they say, but one thing that got my interest from what he said is that even when private sector persons come to support, sometimes they are discouraged by bureaucracy. Wow. You have all these problems, government will say that yes, government alone cannot solve all of them. But when you have some private partners coming in, some government officials will still drag it and delay them, discourage them with bureaucracy. Not good for the poor, our mothers and children, and a lot of FCT residents who are suffering a lot from all these gaps in our primary health care. So, but I also asked further questions to Dr. Iwot on how he and his team in primary health care board intend to address some of these problems. And these are the things he had to say.
One, what you are seeing today is not different from what it has been before the enactment of that law. Primary health care inventory, lots of primary health care inventory and dilapidated infrastructure, and achieving just 30% of the required minimum staffing by number and mix in primary health care in FCT have been a problem over time. And the important thing we have to note is this, that primary health care facilities are still in the purview of the 6 area council because of the gap I'm telling you now. But we are expected to absorb both the personnel and budget of the area council into the primary health care board. And from there we have one plan that would go into the Health and Human Services Secretariat plan that would then translate into the bill from the Health and Human Services Secretariat into the FCTA bill, appropriation bill, that will now be adopted as appropriation act. So if you have that, with the 2% consolidated revenue of the FCT plowed into as one of the 4 sources of financing primary care in the FCT. So if you have that 2% consolidated revenue annual for funding of financing of primary health care, plus the statutory budget allocation, plus funding from partners and the basic provision fund. Those 4 are the sources of revenue of financing primary health care in FCT as captured in the FCT Primary Health Care Board Act 2019. So we have not realized, the only one we have realized is the statutory budget, the basic provision fund for the 1 per ward primary health care center. Those ones are the ones. But where were we before now? There were waivers. We couldn't have started basic provision fund. We couldn't have assessed, we couldn't have gotten accreditation if they were not giving us waivers. Those facilities were still very poor in infrastructural outlook. And the utilities, we are talking about power supply, and we are looking at the national grid. Where you were saying how many of them are linked to national grid. But you and I know that national grid can no more be set to be a standardized way of measuring this thing. There's no power there. And so you are having a generating set. You are fueling it over, the running cost is so high. And so what we are looking at then is that how many facilities are having steady power supply for at least 6 hours in 24 hours. So you have 6 hours because we are looking at the time that it will take for you to have a frozen ice pack that can keep vaccines in a potent form for 24 hours. You must have steady power supply for 6 hours, not that you have 1 hour and after another 2 hours. No, steady, continuous 6 hours. You can have that every day. Adequacy of whether it is coming from national grid or from power generating plant, the petrol, gasoline, or diesel. Probably it is like that. We will accept it as adequacy. Water supply, most of the private care facilities, you know that when they consulted them, they were making a water closet to be driven or to be serviced by motorized borehole that of course are powered by either gasoline or national grid or something, which are not there. So eventually these facilities are having functional toilets. So I agree with this evaluation. So what are we doing? We developed a 3-year infrastructure development plan, taking into cognizance, you know, the situation at hand now. We costed, you know, in our own way, we costed all the facilities in the FCT, and we came up with a budget of about over 8 billion. So what we advise is this, that this budget should be given out to stakeholders in health, corporate organizations. We have Bega here, we have banks, we have corporate organizations. So we have stakeholders, town hall meeting. We present that we want the Minister of State to coordinate this. Then we put this out, let them adopt primary health care facilities. That is one. Then two, beyond that, the facility will be looking fine. You have the water supply, solar-powered electrification, solar-powered motorized borehole, solar-powered everything that you don't need to look for gasoline. But where is the manpower? When I tell you that we are only achieving 30% of the human resource for available primary care facilities, that is to say we still need 70% to meet the minimum. So there are many facilities that are not having staff at all. So after you renovate them, you put them, you furnish and equip them, you need the staff. And the staff cannot come to be ad hoc staff. Ad hoc staff or casual staff cannot serve in the health industry. It's even against the WHO recommendation and the International Labour Organization. So that is what I'm saying. You cannot do that. The overhead costs, the salaries, even the 30% we are having, and they're finding it difficult to pay. So that means the possibility of hiring staff now is very low, because you cannot have health authorities in the area and they will be functional when the governing board in the FCT Primary Care Board is not in place. That is what is the spirit of the law. The law says that they will constitute a board. The board would have a chairman and an executive secretary, who is the chairman of the management team, will also be the secretary of that board. So the executive secretary, if you have an executive secretary, you don't have the governing board, it doesn't work. So these two have to be in existence. What it means is this: the health authorities would produce their plans. They will make their plans and forward these plans to the FCT Primary Care Board, to the executive secretary of the FCT Primary Care Board. The FCT Primary Care Board secretary now would go through this with the management staff and present it to the governing board. The governing board would meet. They meet at least once in a quarter. They will not approve these plans after due consideration, and these plans will be forwarded to the secretary, honorable secretary of health secretariat, to be included in health secretariat plan. So if you don't have the governing board, then the health authorities cannot perform.
Yes, Dr. Iwot there, acting executive secretary of the Federal Capital Territory Primary Health Care Board. So I hope, I don't know what to say, but we'll just keep pushing and hoping that for once we'll get to prioritize health, because health is a 24/7, it's a 24 hours everyday thing. So even when you make progress, you must keep watching, taking action, not leaving anything to chance, because you could make progress, and if you relax, everything could relapse. So it's a conversation that we have to continue on various platforms. You keep following us on our social media handles and also our blog, TalkHealthNiger.com, a Pidgin English health blog. And we keep bringing up these issues. My sincere hope is that citizens themselves, will begin to ask more questions to the authorities, and also more private sector persons will get to support these health facilities. Thank you for watching. My name is Dr. Laz Eze. See you same station, same time next week. Bye for now.